Let's say, for example, somebody has plaque. Has there been any studies, or do we know if plaque can be reversed? And we'll get into calcified versus non-calcified. But to your knowledge, is there a sure shot way by which people can actually reverse their plaque? Is there something people can do?
I mean, I see it all the time in my practice. The first you got to stop doing the damage, and that's the hardest part because most people don't always, think about that part. It's like, you can take all the medications in the world, but if you're not stopping the damage, it's going to keep happening. That's why you see the same type of pattern in the hospitals. That the guy who had a heart attack 2 years ago is the same guy coming in, and he was already taking his statin and his beta blocker and his aspirin and his ACE inhibitor. He's like, "Why? I took all my medicines." Well, you didn't fix the endothelial dysfunction. You didn't lower the inflammation or make them metabolically healthy. And that's kind of a complicated topic to say what's metabolically healthy. But if you don't actually do the things that you need to do to fix the arteries to begin with, you're not going to stabilize that plaque. You're not going to get that plaque to regress. And so you have to have healthy nitric oxide levels. You have to have minimal inflammation, oxidative stress, and then the lipoproteins need to be modulated. Often that ApoB particle has to be less than the 20th percentile. So an ApoB less than 70 before you can even see a possible plaque regression. They used rosuvastatin, which was Crestor in the Jupiter trial, and they were showing carotid plaque regression using intravascular ultrasound. So definitely have been shown that, at the right doses of statins, you can do that. But statins are just one tool that does that.
PCSK9 inhibitors, have they played a role for you in your clinic?
Oh, definitely. I don't know the literature too much on that they have for actual true plaque regression, but it's plausible because they're very potent at lowering ApoB. And, the side benefit is that they also tend to lower lipoprotein A 20 to 30%. Still don't know if that's clinically important, but that's the only benefit that you get from that is, I should say that that's the only thing other than apheresis that really has much of a movement on LPLA levels. But no, I have a lot of patients who utilize them because they're statin intolerant or they're not getting into goals with statins. You know, it's the, you said earlier about, we're talking about genetics, but that's how they kind of figured out this. I have a family member with, a loss of function PCSK9 gene. It's one of the longevity promoting genes because, this person's ApoB has been in their 40s their entire life, naturally, no medicines, no supplements. So the drug companies studied people like my family members, and they created, Repatha and Prevlimid based off of this with the monoclonal antibodies. So, yeah, so we talked about the genes that you can get that worsen your atherosclerotic risk, but there's other ones that actually lower the atherosclerotic risk. And the people who live to 100, that doesn't mean that everybody's going to be able to eat hamburgers and Coca-Cola and make it happen, but there are certain people that their genetics do favor them, but it's test don't guess. Look at your arteries. What is your arteries doing? That's what really matters.
You mentioned stress testing, and at the hospital, it's routinely done to if a person is coming in with chest pain and they don't have any other markers for heart injuries, such as troponins leaking, and the patient is no more having any chest pain. A stress test will do the job, and you will send people home. How good is a stress test? How reliable is a stress test?
So that's a better indication for using a stress test is you're trying to recreate that person's symptoms. Can you get them to have chest tightness or pain or shortness of breath or EKG changes while they're exercising? But exercise is the appropriate stressor. If you can't exercise, that's already put you into a high risk category. Now, if you did had a recent orthopedic injury, that's a little bit different. But like if you just could not keep up it on a treadmill because you're that out of shape, that's a very bad sign. So you always want to try to do some type of exercise, one either a treadmill or bike, or there are old school in the VAs where they got arm cranks. I've seen one of those done in 15 plus years. But do some type of exercise component. But they're not very sensitive or specific to do just exercise. So often you add some type of imaging, so either an echocardiogram or a nuclear imaging component to it. Those get into like the mid 80% sensitive, but you're still going to miss, 15, 20% of people with stress tests. It's rare that it's going to miss a severe blockage in one of the three coronary arteries, but it can. And so oftentimes the symptoms are going to trump whatever the stress test shows. So you just want to see that they have very good exercise tolerance, that their heart rate came up appropriately with exercise and then dropped at least 12 beats a minute in the first minute after exercising, that their blood pressure came up appropriately, but not too high. So shouldn't be, 250 millimeters of mercury systolic. That's a hypertensive response exercise. That's a very poor prognostic feature, even if you don't see ischemic changes on the EKG. So stress tests are good in those situations, but they're not perfect. And so that's why you want to layer on a lot of this other testing.
Thanks for watching, and I appreciate you as a valuable viewer. And if you liked this segment, you can watch all of the different individual segments or the whole podcast to have a broader understanding on this topic. Just check the links in the description or what you see on the screen right now. I'm Dr. Umar Khan. Looking forward to seeing you again. Thank you.